The views expressed in this podcast do not reflect those of our training institutions or the APA. The information discussed is intended for educational purposes only and should not be used for diagnosis or treatment. Enjoy.
Hello, and welcome to the American Journal of Psychiatry Resident Journal Podcast. I'm Barrington Hwang, one of the media editors. We've got Julian Raffoul, one of the journal reviewers, and Dr. Sheryl Fleisch. Dr. Fleisch has been at Vanderbilt and was a champion for many of the underserved populations of Nashville, including the homeless population. At Vanderbilt, she used her unique position as a consultation liaison psychiatrist to establish the Homeless Health Service and Street Psychiatry Service. She has been instrumental, along with her team, to provide excellent clinical care to homeless patients at VUMC and in the community. I'd like to welcome Dr. Raffoul and Dr. Fleisch.
Thank you guys so much for having me here today.
Yes, thank you, Dr. Fleisch, for joining us and participating in this podcast. What are the services for the homeless population that are associated with this hospital?
So right now, I first came here in July 2013, and in July 2014, we established a street psychiatry program where me and 3 residents and a medical student each week on Wednesday will go out on the street and we provide psychiatric services and basic medical care to persons who experience homelessness in Nashville. And then we also have a consultation service for persons who experience homelessness in the medical hospital. So anybody who experiences homelessness and also has a medical problem and is admitted to the medical hospital, any of their teams can consult us, and me and another psychiatrist and a psychiatric nurse practitioner can see them in consultation. What's also really cool is that we also have a housing navigator and a disability coordinator. Our disability coordinator position is unfilled at the moment, but then we also have a social worker. And our goal is really to establish strong disposition plans for these patients who otherwise would likely be discharged to the street or to a shelter location. That's
wonderful. We're curious to know how you got initially interested in the homeless population and how it was to start the homeless psych service here.
Yeah, that's a really good question. So when I was a medical student here at Vanderbilt, actually, I wanted to be an orthopedic surgeon. And that was really my dream. And I had actually done research in orthopedics from when I was an undergrad at Vanderbilt for 4 years, all the way through my second year of medical school.
Oh, wow.
Yeah, it was really what I wanted to do. And one day when I was in the operating room really early in the morning, I crossed that invisible barrier, and one of the surgical techs, kind of snapped at me, and I had this realization that I didn't want to do orthopedics. And I went home and I thought to myself, I have no idea what I want to do with my life. And so for the next couple of years, I kind of went on this journey regarding, what I wanted to do with my career. And as I went through my rotations, I actually did psychiatry first because I didn't want to do psychiatry. And I realized that one thing that was similar in all of my rotations was that, like most of you, I really enjoyed talking to people. And one of my patients on those rotations was a woman who was experiencing homelessness. She actually had achalasia and was vomiting profusely. And she also had malignant hypertension. And I was on my internal medicine rotation, and every time she would come into the hospital, which was 4 times during my 4-week rotation, she was given Norvasc, which at the time was $100. And my team said that if she can basically afford her crack, why couldn't she afford her Norvasc? And medical students are always the last people in the room, but they're always the last people out of the room too. Mm-hmm. And so my patient explained to me that she was uninsured. She had no idea how to, get to the pharmacy to get her medication. And she was also experiencing homelessness. And it was at that point that the light flipped on, that I didn't want to be part of the problem. I wanted to be part of the solution.
That's a wonderful story. So when you were in medical school, you first felt that impulse to help the homeless population. And how did you start the service here at Vanderbilt? What were the barriers initially?
Yeah, so whenever you start something that's really innovative or different, there are always going to be, institutional barriers or legal or risk barriers. So I had started 2 other programs before in my residency and fellowship. And when I came here, I had negotiated to have 20% time protected for the street psychiatry program. But Vanderbilt didn't know, and I don't think I knew either, how extensive the programming was going to be. It was difficult to partner with a nonprofit to get our department on board and to get the whole institution on board. But I was really lucky to have a chairman who was supportive of my effort to build the street psychiatry program and to partner with a nonprofit and their CEO. And then things kind of went on from there. We actually were the first subspecialty service in our consultation liaison program. And we were the first homeless psychiatry subspecialty service in the nation. And I think one thing that is important about that is, when we think about recruiting, residents or medical students into consultation liaison psychiatry, we have to think about, how we intend to do that. And we usually think about homeless healthcare as affiliated with community psychiatry, but we also have to realize that persons who experience homelessness come into the general hospital more than any other population. And so thinking of that in the line of consultation liaison psychiatry is one way to do that. And I think our hospital was willing to put financial backing into something that's also critically relevant to residents and medical students.
That's all really inspiring. There seem to be barriers to setting up these structures. You mentioned 2 services, the homeless psychiatry service in the hospital and the street psychiatry service outside of the hospital. For the homeless psychiatry service in the hospital, what does a typical day look like?
Yeah, so in the hospital, a typical day is going through our consultation list like any other consultation service, and splitting that list really between me and our nurse practitioner. Last year, we were actually able to hire another psychiatrist. So now me and that psychiatrist are on service every other week. So that was a real win for us. But we split our list. I usually take the cases that are kind of extra complex. And when I say that, we're thinking about patients here who are really living on the street, often with a dementing illness, or patients who have extremely severe medical illnesses where their discharge plan is kind of unfathomable. And so we have to work with the medical team on those problems. And then what I do is, just like any other consultation service, I will see those patients, contact the primary team. The difference really is that I work with our transitions management office and our social worker and our housing navigator. So instead of just seeing the patient and making recommendations on the psychiatric illness, there's really a second piece to the puzzle, which is what happens next. So if the person is agitated and I make recommendations on agitation, instead of being able to sign off on the case, that's really only the first half. I then have to figure out, how are we going to disposition this person even if they're psychiatrically stable? Because this person still may not be medically stable enough to return to a shelter environment, or they may not be stable enough to return to the streets. And so that's where our service really can help out, and that's where we honestly spend most of our time.
Seems the true role of the CL psychiatrist is exemplified here. What about a typical day on the street psychiatry service out of the hospital?
Right, so every Wednesday I go out on the street, and then our nurse practitioner remains in the hospital and is seeing our consults in-house. So we're still going there. But every day on Wednesday, I go out on the street along with our residents and a medical student who, our residents are on a longitudinal rotation, and then our medical students have an immersion experience. And so we partner with a nonprofit here called Park Center, and we're always accompanied by an outreach worker. And so from about 8 to 10, we go to one of the encampments in the city. About 6 of the encampments in Nashville have over 20 people at each site, but there are over 75 encampments in Nashville. So we usually go to the larger encampments and we do what we call street rounds. So we wear backpacks, and they're filled with hygiene products, maybe bus passes, food cards, and other items that allow us to engage persons who experience homelessness. And we think of it like meeting an immediate need. So it allows us to build a rapport with that person. We can also figure out how, if the person is having an acute psychiatric illness or has a basic medical need, we can meet that need there. And then we actually have appointment slots at 10:30, 1:30, and 3. And so in those slots, we have outreach workers from the community that refer patients to us. And we can sometimes self-refer from our morning appointments as well, or from the hospital. So just like if you were in the hospital and you were an oncologist and you were on service and you saw a patient, you referred them to your outpatient clinic. If I'm on service and I have a patient, I can refer them to my street clinic. So it's a way to have continuity of care. And so in our clinic appointments, we see people on the street, at their campsite, at a fast food restaurant, and sometimes at the nonprofit location. We're always accompanied by the outreach worker during those locations, and the outreach workers send us referrals through a survey on REDCap. And we work with probably 20 different nonprofits that we partner with one specific nonprofit to provide the outreach experience. We've also done hepatitis A vaccination program and like a naloxone distribution program. So we've had a lot of success with those different initiatives as well.
Can you tell us more about the relationship between the nonprofit Park Center and the hospital?
Yeah, so regarding the logistics of it, we sign what's called a program letter of agreement with them, and that allows our residents to be able to work with the nonprofit as like a physical site, just as if our resident was like working with the VA or any other site. And then we have what's called in EPIC, a mobile behavioral health clinic. So our residents actually document in EPIC, and we're considered a Vanderbilt outpatient clinic. We just practice in a non-traditional environment. All of those logistics were not easy to get started, but my first year when I was here, we established all of those logistics. Regarding working with the nonprofit, we do not pay the nonprofit, and the nonprofit doesn't pay us. The cool thing about our relationship is that what the nonprofit gets out of it is they have patients. Their goal is to house people and to work with individuals who experience homelessness and who have a chronic mental illness. In order to do a lot of those things, they also try to help individuals obtain disability, since we're a non-Medicaid expansion state. Normally what they do is they actually pay an outside psychologist to do evaluations for them, to help them obtain disability. We are psychiatrists, and we provide basically evaluations of these individuals because that's what we do. And so what they do is they end up requesting records from Vanderbilt on the evaluations that we're performing on these individuals. We don't sign any disability paperwork or anything like that, but we're basically doing the evaluations that they were previously paying a psychologist for. And so they're benefiting from that. What we're benefiting from is we have this incredibly rich training environment for our residents and medical students, and that really is irreplaceable. So that's how we've established this very strong connection with the outreach team. Plus, to top it off, they had been in existence for 20 years and never had physicians work with it. The benefit to Park Center, for them to be able to go out with physicians and feel comfortable knowing that if a patient were to ask them a medical question or ask a question about a psychiatric illness, I think brings them a lot of comfort that they will be able to have somebody there that will be able to answer that question. And so it brings benefit to both of our organizations.
Thank you for sharing that with us. It's a very complex service, it seems, and requires a lot of moving parts and a lot of impassioned involvement from the members of the team. When you were establishing the homeless psychiatry service, what were some of the challenges in establishing and ultimately maintaining this service?
So there are always going to be a lot of barriers when you're starting a service that is very unique and something that has really never been done before in a hospital, and then being able to maintain that is particularly challenging. I think when I had started the service, everybody was really excited about it, and so the initial parts were, while challenging, very exciting. I think maintaining the service, some of the major barriers were being able to show our value. So one of the major challenges is that our nation really goes by what's called a fee-based system. So we value volume. So if you see a lot of patients, then you get paid more. And if you were on a schedule where you're supposed to see, let's say, 10 patients a day, and you see 11, then you might be rewarded for that. We are in a service in our inpatient environment where the likelihood that we are going to meet a certain number is very unlikely, because we can't determine if there are going to be a certain number of patients who experience homelessness that will come in a certain day. Maybe one day there would be 12, and another day there would be 8, and maybe on some days there will be 2. The other thing that's very challenging is that what if those 2 patients are so complex? What if the 2 patients equal 12 patients? It's very difficult to prove that to a hospital and say, like, look at how valuable we are. Look at how much we care. Look at how much you should value us. Look at how many emergency room visits we save. So trying to figure out what a hospital system values, trying to figure out what metric the hospital system will consider going by, and then figuring out who to speak to. So I guess 1, knowing the audience, and then 2, understanding that metric. So going one step farther, I think for us, we learned that trying to get ourselves on what's called a non-RVU model, so making sure that we were not on a volume-based model, was a really big win for us. And then making repeated presentations to the hospital regarding the fact that we were going to be in what's called value-based care. We wanted to tie our outcomes with what happened to our patient. So if our patients were housed, if our patient's hemoglobin A1C decreased, if our patient stopped using alcohol, so tie our outcomes with the patient's outcome is how we believe that medicine, the future of medicine is. And we wanted to try to teach that to our hospital system instead of going just by a volume-based system. And I think so far we've been really successful in doing that. And that is overall what allowed us to be able to increase our FTEs, which is our full-time equivalent, and be able to hire on another faculty member. But this wasn't without a lot of challenges and without a lot of presentations. But I think when you hit like a barrier, you have to figure out a creative way to go around that barrier.
How long has it been since you've started the homeless psychiatry program and started to see the metrics actually materializing?
So the program started in October 2015. I actually hired the hired the housing navigator, disability coordinator, and nurse practitioner all right around that time. So in October 2015, I hired the disability coordinator. In January 2016, I hired the housing navigator. And in February 2016, I hired the nurse practitioner. It was about 2 years later, I was able to hire a social worker. And then it was a year after that, I was able to hire another psychiatrist. So it has been a gradual process, but I think the effort has shown, and I think that sometimes we wish that it had been a year earlier, or it had occurred during this month. But when you really look back at the numbers and you see when it all happened, I think it has been really at a very gradual and appropriate pace.
We're going to turn the corner and switch gears a little bit to some of the current listeners who may be residents or others that are interested in a career in medicine/psychiatry. What advice would you give them early in their careers on how to pursue homeless psychiatry or a career track that you've taken yourself?
First off, I would say that don't give up. I think a lot of times when you're trying to pursue something that isn't necessarily readily available at your institution, it's easy for someone else to say that, we don't have this here. And I've been told that a lot. We don't have this here. This educational opportunity isn't available. It's okay. You can try to create it. Oftentimes I was given half a day. And I always said to people, that's all I need. Can I have half a day? So ask for half a day, figure out how to get half a day, and then figure out your partnerships from there. When I was a resident and a fellow, I utilized half a day to develop partnerships with other organizations. So it will take a lot of persistence, and you are going to have a lot of barriers. You'll have legal barriers and risk management barriers, and a lot of people will ask you questions about going outside of the hospital setting. But use your relationships. The one other thing is that there are two other organizations. One's called National Healthcare for the Homeless Council, and another one is called the International Street Medicine Institute. For anybody who is interested in a career in homeless healthcare, I would highly recommend going to either one of those websites. And then the other thing is that going to there's also a community psychiatry listserv. It's free for residents. And so I would recommend being a part of that. I am as well.
Seeing how you innovated and made something you care about as part of your future career is certainly inspiring. Your role seemed professionally and personally fulfilling on many levels. Could you tell us a little bit more about a patient experience that has resonated with you during these roles?
Yeah, there has been numerous patient experiences that really change your life. So there's a patient, I'll call her Miss S, and I first met her my first year as an attending here, so nearly 7 years ago. And I actually heard her before I saw her, because I was sitting on one of the units in the medical center and I heard this woman screaming. And she is the person that you walk by and you hope that she didn't look at you, because you don't want to go into her room, and then you feel really guilty when you walk by. And I remember literally doing that, and then I realized, oh my gosh, she's my patient. And that happens to all of us, and you have that really guilty conscience and that feeling. And so I remember hearing her and then being like, oh my gosh, she's the patient I was consulted on. And so I go into her room, make a very long story short, she had a very severe opioid use disorder for like 37 years. And she was living in a crack house, and she had been in very bad situations for a long time. And after a series of multiple hospitalizations for a period of probably 7 or 8 months, where she spent probably 100 days total in the hospital between the medical hospital and the psychiatric hospital, where we provided numerous kind of heroic disposition plans. And those are the times where you are like, take the disposition plan. This plan is amazing. And then the person does a different disposition plan that puts them at risk. Ultimately, on the last time, I remember literally sitting on her bed and saying to her, I have called this nonprofit organization, and they are willing to give you a tent and a place to put to go. You've burned your bridges with every other place. This is your very last opportunity. You are going to die if you basically don't do this. And after a very difficult discussion, she and her husband actually ended up staying in this tent in the only sanctioned tent community here in Nashville. Again, to make a very long story short, ultimately she ended up going to an IOP program. Ever since that day, she's actually been sober, and her 5-year sobriety anniversary is at the end of June this year. And so once a year, we actually take her out for food, and she picks like wherever she wants. And a couple of years ago, she actually spoke with me at an event here at Vanderbilt. And like the head of all of Vanderbilt like sent her a letter, and it was extremely exciting for her. And I literally never thought, A, that she would survive, and B, that I would be, standing next to her, like speaking with her. And she actually called me the other day to like remind me that we needed to like go out for her like 5 years. And I was like, don't worry, I remember. And I just think that it shows us that we all have these biases, and I always thought I was non-judgmental, and then we always have these like subconscious biases, and I think she's taught me so much over these years, and also that really anybody can recover. She was somebody who I thought, I don't know if she's going to get better, and look at her. She's like thriving 5 years later. She's housed, she's sober, she's managing her money well. Like, she's doing an amazing job.
That story is very inspiring and allows us to see the other side. Do you have any final thoughts you'd like to share with us regarding your overall experience?
Developing programs is exciting and it's fun. It's hard to do. It's totally worth it. For anybody who's listening who is interested in A, program development, or B, interested in provision of care for folks who are underserved, or providing care for folks who are homeless, it's something that is possible. It's something that can be done. And the other thing is that it's possible to do it even if you have other interests. So I've always wanted to, once I decided I wanted to do psychiatry, I always wanted to be a consult psychiatrist. And I was always told that it was not possible to mix my interest in consultation psychiatry with education, with homeless psychiatry, and you can't have your perfect career. And it's hard to have your perfect career, but I think it is possible to kind of develop what you want. You just have to, work hard to kind of make it happen. And also not everybody has the best outcome, but there are positive outcomes for people. And like you were saying, a lot of times as a resident or a medical student, we don't normally see that. But I do think it's important to see the flip side of some of these cases, because it is really easy to get burned out. And also a lot of these cases too are very challenging, but a lot of the folks that we see are just so grateful that we're providing care. And it's important to remember that what we do does matter. And I'm also more than happy to answer any questions if anybody who's listening has those.
Feel free to leave those questions in the comments or send us an email. Again, we appreciate your time with us, Dr. Fleisch. We really need more people like you to show us how to nurture the humanistic aspects of medicine in the clinical setting. We appreciate you listeners as well for listening to the American Journal of Psychiatry Resident Journal podcast. If you have any suggestions or topics you would like to see or hear, send us an email or come interact with us on social media. Go ahead and click subscribe as well. We look forward to tuning in next time.
Thank you, Dr. Fleisch.